started. So my name is Kara McAnuel. I'm the clinical manager for the Baycrest Behavior Support Outreach Team. I'm welcoming you today for our behavioral support rounds entitled Non-Pharmacological Approaches to Managing Symptoms of Psychosis. Next slide, please, Agnes. So a few things to go over first and foremost, the land acknowledgement. Although we are meeting virtually, we acknowledge that Baycrest and our related Toronto, Ontario Health Area behavior support programs operates on the traditional territories of many Indigenous nations, which have cared for the land for thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis people, and is subject to the dish with one spoon wampum, an agreement of peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationship to the land and to the people who are the traditional keepers of the land. Next slide, please. Some housekeeping items. So please note this session is being recorded, as you would have heard. It will be archived on the Ontario CLRI and BSO websites afterwards. Your microphone is automatically muted. You will have about 40 to 45 minutes of presentation, followed by about 15 minutes of discussion and a wrap-up. Please place any questions that you might have in the chat or the Q&A on your Zoom. If you have questions related to tech support, please message Agnes directly. For those of you who are interested in receiving a certificate of attendance, please enter your name and email address in the completed evaluation form that you'll receive via email afterwards. Next slide. So I'm delighted to introduce our speaker, Dr. Yael Goldberg. She is licensed by the College of Psychologists and Behavior Analysts of Ontario in Clinical Psychology and Neuropsychology. Today is World BA Behavior Analyst Day, just so everyone's aware. Within the Virtual Behavioral Medicine, so VBM program at Baycrest, she supports healthcare teams and families in managing behavioral symptoms of dementia. Dr. Goldberg supervises trainees at various levels of training and serves as the Director of Training of Baycrest Pre-Doctoral Internship in Clinical Neuropsychology. So warm welcome to you, Dr. Goldberg. The floor is yours.
Thank you so much, Kara, for inviting me and having me here today. Just a brief note to say that I'm a little bit under the weather, and so please bear with me and thank you for your patience as I navigate the throat lozenges with tissues and drinks. All right, so I'm going to share my screen. Just give me a minute to do that. Okay. Excuse me. All right, so today I'm here to talk about how to manage symptoms of psychosis, so hallucinations and delusions in persons that have dementia, which contribute to their overall distress and their functional decline. So first, just a couple of slides to show you that I have nothing to disclose and no bias. Okay, so today I'm going to review the symptoms of hallucinations and delusions and talk about how they most often present in dementia. We'll learn how to think about the symptoms from a non-pharmacological lens using principles of applied behavior analysis, or ABA. And then I'm going to share some practical strategies for symptom management. So just to kick us off, our first topic is understanding hallucinations and delusions. So brief definitions. A hallucination is the perception of something in the environment where nothing's actually there, right? And we can have different kinds of hallucinations across all 5 senses. So it can be hearing, seeing, touching, smelling, feeling inside. So some examples that are probably more familiar to you are, seeing people who are not there or hearing voices that are not speaking. And delusions are strongly held false beliefs that persist even when evidence is presented to the contrary. And there are a bunch of different types of delusions as well. Probably the most common or the most well-known in dementia are the persecutory or paranoid, right? Like someone's out to get me. But more common, other common examples is, believing that one of your caregivers is an imposter, that the spouse is having an affair, um, being poisoned by the nursing staff and therefore not wanting to eat or take medicine, that the TV is talking directly to them, or we actually had one patient on the behavioral neurology unit several years ago when I used to work there, who she believed that she was actually best friends with Dr. Morris Friedman, and the reason that she was there was because she was there to help him with a research project. Okay, so about 20 to 50% of individuals with dementia will experience some symptoms of psychosis. And hallucinations in dementia are most often visual, like seeing people, animals, shadows, right? Or auditory, so hearing voices or music. They're also more common in people that have Lewy body dementia and a little less so in Parkinson's disease dementia. And delusions are more frequently of the paranoid type, like I mentioned, so believing that someone was stealing, infidelity, someone's out to get them, or they're being persecuted somehow. But they can also involve some misidentifications. So, for example, in something like Capgras syndrome, right? So, believing that a loved one has been replaced by an imposter, for example. And delusions are more common in Alzheimer's dementia. Excuse me. Whereas hallucinations tend to appear early in the disease process, delusions tend to be more pronounced later in the disease process, but both symptoms can fluctuate in severity, depending on what's going on. Most often, they're worse during times of stress or illness. So let's talk a minute about the impacts on patients' well-being and the caregivers who are providing care for them. So when in the context of symptoms, it can increase, in the context of psychosis or symptoms of psychosis, it can increase other neuropsychiatric symptoms, right? So they're more distressed, they're more agitated, they're more resistant to care. There are greater risks to their safety. For example, increased wandering, exit seeking, aggression. There's also more emotional and physical strain on caregivers who have to manage these symptoms of hallucinations and delusions, which can increase rates of burnout. And also, there's more of a likelihood that these individuals are going to need to be hospitalized or placed in long-term care or some other environment outside of their home. And so, understanding the early signs of psychotic symptoms can allow us to intervene in a timely way and get ahead of things. And if we can implement some behavioral or non-pharmacological strategies before symptoms escalate, excuse me, patient outcomes will be better and caregivers will be less stressed, right? So we want to try and identify and treat early on. And we do this by encouraging a very supportive and structured environment that can help minimize distress and enhance well-being for everyone involved. And I'll talk more specifically about how we do that in a little bit. So when we treat psychosis and dementia using medication, it's not without its challenges. So first of all, antipsychotics are ultimately not always very effective. For instance, if a delusion is there and it appears to trigger aggression, giving medication might be helpful, might be necessary because of risk, but the underlying belief can be very resistant to change just by medication alone. There's also an increased risk of severe side effects, right? Like, the drowsiness or sedation. Some people have called it being snowed or gorked. Those are not clinical terms. I don't recommend them. Falls, like, due to gait instability and even stroke. So it's pretty clear that we need to have some safer non-pharm interventions to help improve symptom management. And so that's what I'm going to turn my attention to now, which is the non-pharm management of the symptoms using an ABA or applied behavior analysis approach. So for those who are unfamiliar, ABA is a structured, evidence-based approach to understanding and modifying behavior. The premise is that behavior is learned and it can be modified. And the focus is really on, excuse me, the focus is on identifying triggers and reinforcing positive behaviors that we do want to see. And through this framework, we can figure out what purpose a behavior serves, like why the person is doing what they're doing. And we can provide individually tailored strategies to help manage their symptoms. And to do this, we rely very heavily on the ABC model, so antecedent behavior consequence. We're looking at what happens just before the behavior of concern, what happens just after the behavior of concern. And so we see the importance of environmental and contextual factors in shaping behavior. So the idea here is that everything happens for a reason. There's a reason for why we do what we do. And there are four reasons that are most common as to why people engage in any sort of behavior at any given time. And we can use the acronym SEAT, S-E-A-T, to help us remember what these four are. So for example, if I scratched my arm, I don't know, I can't see myself. Hopefully you guys can see me. Okay, there, now I see. If I scratch my arm, why am I doing that behavior? Because it feels good. Maybe I have a mosquito bite, my arm is itchy, so the behavior I scratch, I feel better, right? So there's that sensory stimulation. That's what the S from SEAT stands for. People do things because they're seeking an enjoyable or a comforting sensation. It could be tactile, like I just scratched, or it could be intellectual. They're bored and they're looking for some kind of intellectual stimulation. And this applies to all humans, not just our patients. The next most common function or reason why we do what we do is to achieve escape or avoidance. We're trying to escape or avoid doing a task or a situation that we find displeasing somehow. It's aversive to us. It brings us distress or discomfort. Excuse me. So I'll give an example of that in a minute in more detail. Next, we have attention. So this is where behavior is done in order to get a reaction, whether it's positive or negative, doesn't matter, right? Even a reprimand is attention. So they're really seeking to engage with you. And lastly, tangible. And this is to gain access to something, a food, a toy, an item, an activity, even a person sometimes. And so when we look at antecedent data, meaning what happened just before the behavior, and the outcome data, the consequence, right? What happened just after, we can start to figure out patterns and narrow down which one of these four functions a behavior might be serving. So I'll give you an example now as promised. So the first thing we're looking at is behavior, right? So first, the behavioral response. Patient hits and spits on the PSW. What behavior is that? It's aggression. Okay. Then we want to look at what happened just before, the antecedent. The PSW arrived and said to the patient, "It's time for your shower." Okay. Then the patient hits and spits on the PSW. And then what happens? Well, 3, the consequence or the outcome. The PSW leaves the room. So in this interaction, in this ABC, what happened here? What was the patient trying to get? Think back to what we just talked about with the seat. Think back to the antecedent, the consequence, PSW left the room. What do you think the patient was after? If you said escape or avoidance, you're right. So the patient learns through this whole process that if they want to escape, all they need to do is just hit the PSW or spit on them, and then PSW is going to leave. And it's like, I did not have to take a shower. Yes, right? Relief from the distress. And so that's how behaviors might be getting reinforced. And so the goal of our non-pharm strategies is to give the person what they want, the escape, without them having to engage in behavior in order to get it. So if we now look at an example with a symptom of psychosis, right? We start with the behavior. What happened? Well, the patient was trying to leave, insisting that he has to go to teach a class, right? So there's this belief that they're a professor at university, they're late, they have to get to class. And so to figure out what function this might be serving, we need to know what happened just before, And how did people around him react to his exit seeking, to his delusion? Was he feeling anxious because there was a shift change just before, right? And then when he was trying to exit, insisting that he was late, did the staff come over and give him some attention or did try to talk him out of it? Did they rationalize with him? Maybe did they move him to a secure area? Right. So all these things, remember we talked about how environment and context really matters and can shape behaviors. So step one in designing any sort of non-pharm intervention is to do an assessment so we would do a functional behavior assessment or FBA to figure out what happened just before, what happened just after, because we're trying to hone in on what the function of a delusion is. We're looking for patterns. We're looking for how the environmental responses might be reinforcing the behavior. And this is going to guide us to develop appropriate interventions that are specific for that person to meet their needs. So for example, let's say we were analyzing the function of delusional speech, right? Interventions can be designed to reduce the frequency of the distressing or disruptive statements because we can figure out a way to give them what they're seeking without them having to engage in the behavior to get it. Excuse me. And part of that assessment that we're doing is examining risks to safety, right? We're going to be assessing the risk to the patient, to those around them, family caregivers, staff caregivers, and this will tell us how urgently we need to take action with our interventions. Um, okay. And finally, just wanted to say that when we look at the individual triggers, we can also differentiate between behaviors that are the result of a psychiatric illness, right? So if someone has hallucinations and delusions because they have a psychiatric illness, or because they're having those hallucinations and delusions for a different reason, potentially. So I'm going to walk you through some common triggers because hallucinations and delusions are not always the result of an underlying psychiatric disorder, right? They can emerge in dementia for a lot of other reasons. So first would be unmet needs, right? If the person is hungry or thirsty, they're in pain, they have some discomfort, that might manifest as paranoia or agitation. Similarly, if they're tired and their sleep is disrupted, that can increase the likelihood of hallucination. Next, we have sensory deficits, right? So if there are visual or hearing impairments, that can contribute to misunderstanding, misinterpreting what's going on in the environment. You know, if they see shadows or reflections, background noise, that might all lead to visual or auditory hallucinations. Then we have unfamiliar environments or changes in routine, like basically environmental factors. So for example, moving to a new setting, or like a hospital stay, like moving, you know, from LTC to acute care or vice versa, can heighten confusion and delusional beliefs, right? Because we're messing a little bit there with orientation. Lack of familiar cues could increase misidentifications, paranoia, you know, poor lighting, right? Again, with the, oops, misperceptions. Excuse me one second. Thank you. Okay, one more second. Then we have some social and emotional triggers of hallucinations and delusions. So feelings of isolation or fear can contribute to delusions of abandonment, right? Like someone left them behind or that they're being persecuted, someone's out to get them. Unfamiliar caregivers or visitors could be misidentified as intruders, again, delusion of persecution or paranoia, as some might call it. And we have medication side effects. So certain medications can actually exacerbate psychotic symptoms. I'm not going to dwell too much on that right now. It's not my area of practice per se. And medical conditions. So underlying infections like UTIs or metabolic imbalances like dyslipidemia, and there are many, many others, delirium. This can all cause sudden worsening of hallucinations or just like emergence of them. So in all of these scenarios, excuse me, that you see on the screen, I'll walk you through them. These are basically like the common, so we talked about common triggers. Now we're going to talk about common outcomes, um, or common responses by staff or family caregivers when there are psych I'm so sorry, psychotic symptoms being presented. So some might rush over and see what's wrong and ask what the patient needs, right? Or check for any of their physical needs. Um, Try to talk to them and then try to rationalize away the belief or the perception, like, no, nobody's actually there, or no, you're not a teacher. You don't have to go to work. Um, Removing the patient from a common area, right? Because it's very disruptive, for example, to other patients, and so they just want to put them in a quiet room or isolation or back to their own room. Or they might try to de-escalate by offering something a patient likes, like, oh, come over here, I have this candy for you, or whatnot, right? Um, so in all of these scenarios, the caregivers, the staff are very well intentioned and they're trying to calm the patient down. But with all of these, there's a chance that inadvertently they're reinforcing the behavior. In the first two examples, right, like rushing over to see what's wrong or trying to rationalize it away, um, one of the outcomes of the symptom is attention, right? So the patient is actually getting attention. What if that was what they were seeking? In the third one, removing the patient from the common area gives the person escape, right? They got to escape from this setting where they are. And finally, the fourth one, trying to de-escalate by offering something. Maybe the drive there or the function there is tangible. They want something. They want a candy or whatever it is. I'm not saying that's always the case. I'm saying these are possibilities that we have to consider. And so once we've identified the triggers, and then we've looked at the outcomes of how people in the environment are responding to the hallucinations and delusions, we can begin to establish patterns of behavior, identify their functions, and start developing individualized strategies. So that's what I'm going to turn to now, is provide some practical strategies. So, excuse me, first, we're going to talk about managing hallucinations. And we want to modify the environment to minimize distress. So here are some things you could do. Improve the lighting to reduce the misperceptions. Minimize mirrors or reflective surfaces. So you might want to cover those. Or glass doors or something, put tape across. Reduce noise. That can be done in various ways, noise canceling headphones, white noise machines, something like that. Um, Use familiar objects to orient patients. Like you see a lot in care homes, that there are personal effects outside the patient's room to orient them that, oh, those are my kids, this must be my room, stuff like that. And then we can also try and engage a patient in meaningful activities. So a couple of examples would be like providing sensory stimulation through massage or other means, um, giving them the intellectual stimulation or cognitive engagement, right? Listening to music, doing art therapy, providing them with structured routines and schedules so that there's predictability. They know what's going to happen next. They know that lunch always comes after art, for example, and after lunch always is a nap. And so like they can sort of like take their day as it comes, knowing what to expect. And so these are all fine and good, but what happens in the moment if someone's having a hallucination? How do we redirect a person or de-escalate them in the moment of crisis? So I wanted to share this video with you. This is a picture here of a woman named Teepa Snow, and she's quite masterful at what she does. I encourage you to like look her up if you're interested. She's got lots of stuff out there. Um, but anyway, I want to show you this video now.
Looks like we're having some hiccups with technology.
Yeah, I think she disconnected.
And no problem. Okay, so for those of you on, please.
Okay, so I just learned that I lost everybody as I was sharing this video. I'm going to try again. If it doesn't work, the link is in the slides, and so I will encourage people to watch on their own. But if I lose you again, Kara or Agnes, can you just let me know right away and we'll go again. All right. Okay. So trying again. Maybe this time I won't make it bigger, just in case. I don't know.
There's no sound, unfortunately. When you
Okay.
go to screen share, yeah, just click the sound.
Yep. Let's go again. Technology's
Third
awesome.
time a charm.
Yeah. There shouldn't be sound yet. Wait.
Please,
Do you hear it now?
please,
Okay.
get that little boy, that one right there, get that little boy. Look at him. I'm worried about him. Help him. Help him. He needs help.
Okay.
That one, get it. Now, you can tell by her face. Did you see it? What did her face say? What the hell are you talking about? And her whole body's going, okay. And what is she telling me? Diss me. So what she wants to do is, which is my dominant side? On my body, it's the right. You want to approach from the person's dominant side because, do this, you'll draw their gaze to that side. Human beings like people on their preferred side. They pay more attention to data on their preferred side. They like auditory data coming in on their preferred side. They prefer to be touched on their preferred side. So what I'm doing is setting it up so that if she comes to that side, what will I pay less attention to? The thing that was over here, which I was really focused on, and so she's going to start off far enough away so that she goes, Teepa, hey. And if I see her and call her in, she wants to come in and get connected to me. Hey, come here. I need you to get, yeah.
Hi.
Hey, listen.
How are you?
Well, I'm not good. That
Okay.
little boy, I'm worried about
Little
him.
boy, you're worried about?
Yeah, you see him, he's up under there. You see how he's gotten up under there, and I'm afraid he's going to get hurt. Can you get him out of there? You want me to get him out of there?
You want me to get him out of there?
Yeah, somebody needs to get him out. Somebody does.
Somebody needs to get him out?
Somebody does.
Somebody does need to get him out.
Now those are the same exact words. What was different?
Does.
What was she taking control of? The situation. The situation. And so what you want to do is let me know, do I have to be in charge of it anymore? No, you're going to take care of it. You're absolutely right. That little boy should be getting out from under that. That's not okay. Yeah, kids shouldn't be up under there, should they? I bet you were always real good with your kids. I bet you didn't have, oh yeah, no, they'd get into weird places. My son once crawled up in somewhere, and you know what? We had to break, he got his head stuck in a rubber tire.
Oh my.
Well, not his head, the other part of him. I can't think of what it is. This thing here, where he gets that. He got in there and we couldn't get out, and we tried lard. My grandma said try lard. We tried lard. Now what happened to talking about or worrying about that?
Nothing, it's gone.
Well, it is for right now. Guess what though? If it's Lewy body, it'll be back. It'll be back. They're repetitive more in the evening and at night, and distress.
Okay. Gonna get back to the show. I'm gonna go back to the slide we were at. Give me a minute. Here it is. Okay, are we good, Kara? Agnes, anyone? Thumbs up? Yeah, okay, excellent. All right, thanks for your patience. So, you've all seen this video. Like I said, I really encourage you to look her up on YouTube and other places. She's fantastic and gives really good practical advice. So now we're going to share a case example. I've called this Mr. Smith and the Intruders. So this was an 82-year-old man that had Lewy body dementia, and he would often report that he saw strangers in his room. And he was very distressed and he was afraid to sleep at night because, you know, there's someone in his room. He was scared to close his eyes. He thought they were going to get him, etc., etc. But it all started with seeing these strangers in his room. And so what did we do? Well, we do our assessment as we, you know, that's always going to be our starting point. And it revealed that at night, what was happening was shadows from the streetlights were being cast into the room and triggering misperceptions. Okay, so now we know that it's happening, something's happening at night, and this is what we need to address. So we recommended modifying the environment by installing blackout curtains and then just getting like a soft night light to reduce any of the shadows or ambiguous shapes, figures in the room. We also recommended engaging him in a relaxing bedtime routine. So, you know, listening to familiar music to set him at ease and reduce his anxiety, and, you know, pairing that specific music with bedtime. So he knows, like, okay, when that music's on, it's time to start to unwind. There are other things you could do as well, like progressive muscle relaxation or guided imagery. So just kind of like having a routine before bed. And the outcome of that was, after these things were implemented, the frequency of the hallucinations decreased, and he reported that he was feeling more secure at night. So you can see, just by modifying the environment a little bit, we can help with some of the symptoms. Now we're going to talk about how strategies for managing delusions. So first we have redirection and validate feelings. So what we want to do is acknowledge the distress, like you saw she did in the video. Like, yeah, like the boy does need help. The boy does need to get out from under there or whatever. And gently redirecting to another topic, right? So an example would be, let's say there's you know, someone is telling you about infidelity of their spouse, right? So saying, wow, that must be so tough. You must be feeling so awful. Tell me about your kids. You know, like, so just kind of like push them over. Or, oh, there was once a show where, you know, so and so was cheating, or so and so, did you ever watch that show? What kind of TV do you like to see? And, you know, just moving them along. Another approach or another strategy would be modifying the way you communicate. So first of all, we want to always avoid, you know, trying to talk them out of it, try to confront them. We don't want to do that. We don't want to make them wrong, right? What we wanted, unless there's a risk to safety and we need to address that. But typically, we don't want to try and talk them out of it or say that they're wrong. We just want to use clear and simple language to redirect. So let's say that, for example, and we actually had this one on 4 West. There was a man there who believed that he was the CEO of a large company, and he was late for work. And so he could not participate in the activity that we had planned for him to do. No, I can't do that. I'm late. I have to leave. And so my student at the time said, oh, let me check your schedule. Actually, they've cleared your whole schedule for the day. Let's go, and whatever the activity was. Then we have environmental adaptations. So creating a safe and familiar space with recognizable personal effects, just to ground them. And then this one's really, really important, providing consistent responses across caregivers. So if, let's say, some people react one way and then other people react another way, then that's just going to reinforce the behavior. Everyone's got to be on the same page about how they're going to treat the delusions when they actually happen. So now I just want to take a minute to talk about some reinforcement strategies. What we want to do is identify moments of calmness or appropriate interactions and reinforce them so that we encourage the likelihood of them happening again. For example, when a patient does something you want them to do, or maybe they're just sitting nicely and calmly, giving them verbal praise like, hey, you're sitting there so nicely and quietly, or, a comforting touch, right? So you're reinforcing the behavior you do want to see. If we applied this to delusions, if a patient was telling staff about delusions and then they were getting a lot of attention over it, then the patient would likely keep doing it if the attention was something they were after, right? So if we're able to give him more attention for appropriate interactions, then it will limit the delusions because he's getting more attention for non-delusions or non-delusional speech, right? So that would limit the delusions, and then he would be engaging in more appropriate or meaningful activities. Next, we have differential reinforcement, and this is where we use reinforcement to encourage alternative, appropriate behaviors instead of the disruptive ones. So, for example, if a patient's using delusional speech, encouraging reality-based conversation to shift the focus away, right? Like she did in the video. If a patient becomes distressed by hallucination, just doing some kind of grounding activity, like here's a familiar object, instead of reacting to the hallucination. Simple or using simple reinforcement systems like a routine with structured rewards can also be very effective. For instance, if you were to create a routinized daily schedule that had activities planned at the same times in the same order, as I had mentioned earlier, right? Like nap always after lunch and this always before that, that can create some predictability and minimize the distress. And finally, it's really important to select reinforcement strategies that are based on a person's individual needs. So think about their level of cognitive impairment, right? What they're capable of, thinking about their preferences, their interests, when you decide how you're going to give reinforcement. And there are different ways that you can give reinforcement. You can give it socially, right? Like smiling at them or validating their emotions, using a reassuring tone, the verbal praise. And that might be the most effective in advanced stages of dementia. You can also give tangible reinforcement like a touch, a warm drink, a favorite song, a sticker. And so the key here is to use what you know about your patient to select the best method of reinforcement of other appropriate behaviors. So now we're going to talk about another case. I've called this one Mrs. Jones, the Children and the Thief. And so the background here is that there's an 85-year-old woman with moderate stage Alzheimer's disease, and she has visual hallucinations quite often. She sees children playing in her living room, but actually nobody's there. And then she gets very distressed when she tries to interact with the kids and they don't interact back. And she gets agitated when her family tells her that actually nobody's there and that their kids aren't real. She also has delusions of misplaced belongings. She's constantly accusing her caregivers of stealing from her. And so how are we going to approach this? What are we going to start with? You got it, an assessment. We do our assessment, we find out that the hallucinations are occurring more often in the late afternoon and early evening. Okay, that tells us that there could be a sundowning effect. We also learned through our assessment that the hallucinations happened more often at times when the lighting was low, when there were more shadows, and she was more tired also. They were happening more often when she was tired. We discovered that delusions that someone was stealing often happen when she couldn't remember where she put things. So those were the triggers, right? We identified all those triggers. And so now let's turn to our interventions. So we'd recommend improving the lighting. That's an easy one to do, improving the lighting in the common areas to reduce the shadow formation. Cover reflective surfaces, right? Like mirrors, glass doors, that could be contributing to the misinterpretations. And then working with them to create a structured evening routine to minimize the distress caused by fatigue. So similar to what I described in the previous case. And then teaching them to use validation. So instead of correcting Mrs. Jones, engaging her in discussions about the children and then gently redirecting her to other pleasant memories, other topics, etc. To address the delusions of theft, asking them to designate a specific drawer where she could put her prized possessions and then giving her a key on a bracelet that she could wear. So when she couldn't find something, the caregivers can direct her to the drawer, and this will reduce accusations of theft. Also, teaching the caregivers to give her positive reinforcement when she could discuss her misplaced items very calmly. So instead of that panic and, oh, you must have taken it, but, oh, I don't know where this is. So the appropriate verbal expressions get reinforced. So you see here that a lot of the focus was on educating family or staff caregivers not to contradict her experiences, but to use gentle redirection and positive reinforcement. And through that, there would be less distress related to the hallucinations, fewer accusations of theft the more she used the drawer, and the interactions between herself and people around her became more positive, which means that everyone is a little more at ease. Okay, so I've shared a lot of strategies with you today, but there are a couple of factors that really need to be in place in order for them to work. So first, it's critical that all caregivers, whether family, staff, everybody, respond to patients consistently in the same way. If some staff do and some staff don't, it could actually make things worse. So the more consistent across caregivers, the better the outcome. Another key ingredient is that the non-pharm strategies are most effective when multiple disciplines are involved, right? The strategies are integrated into like a bigger care plan, and that way everyone's on the same page, they're working together, we're capitalizing on each discipline's strengths in order to provide the best possible care for this patient. And finally, as dementia progresses, patients evolve, their needs evolve, it's important for us to monitor the implementation of the strategies. It's important to monitor their effectiveness, right? Something that worked initially might stop working as the disease progresses. And so we need to look out for that by doing constant assessment and then just modify the strategies or adapt them as needed. So we all know that dementia can be a moving target, right? When the disease progresses, then it's like whatever was normal, now all of a sudden there's a new normal. So we have to adapt to treat the new normal. And that just keeps happening as the disease evolves. I'll spend a brief minute here talking about some challenges and things to consider when taking a non-pharm approach. So it's important to make sure that the strategies that you suggest provide dignity and respect to your patients. We want to avoid coercion. We want to give them as much autonomy as possible. We also want to balance the effectiveness of the strategy with their well-being. So if it's something that you know is going to improve the behavior, but it's causing them some distress, that's not going to be a strategy that we're going to want to continue using. We don't want to cause more distress. And we would need to get informed consent for the strategies and get the family involved in planning wherever possible. A good example of that would be simulated presence for, video or audio recordings of family members or friends to play when they can't physically be there, but those can offer comfort and support to patients. And so again, POA's got to consent to that and be involved in preparing those recordings. There are some limitations when it comes to using non-pharmacological approaches in dementia care. So I just want to make you aware of a couple of those. So you can only suggest strategies that are a match for the patient's cognitive state, right? And as the cognition declines, you might be more limited in what you can implement because the capability is just not there. And also, as we talked about with disease progression, things are always changing. So you might need to keep assessing and adapting Something else that I often come across in my practice is that not all the strategies are feasible in every setting. So for example, let's say I suggest a proactive attention plan and planned ignoring, right? I'm often told, well, we don't have the staff for that. We can't go give her 5 minutes of attention every 30 minutes. That's just not doable. Or we can't ignore her when she calls out because it's against our policy, right? So these things can make it really tough. But I think the hardest thing of all is when you don't have buy-in from caregivers or like family caregivers or staff caregivers for your non-farm strategies. And there could be lots of really valid reasons why there's resistance from staff or families, right? They could be unfamiliar with non-farm or ABA. They may not understand the rationale behind the strategies. They could just not have enough time to implement the strategies, right? So like, for example, one of the strategies I often recommend for escape is to give a lot of breaks when doing care so that a patient can have escape without engaging in like aggression to get the escape. And I'm often told, well, we can't do that because it's going to prolong the care episode for so long, and we have so many other patients that we need to see, right? So they just legitimately don't have the time. They could be emotionally tapped out or burnt out after dealing with this for such a long time. And it makes it really hard to marshal the energy and the motivation to implement a new approach, right? They might not believe that it's going to work, so they don't want to put in the effort to try. They're just so burnt out. So really, I want to emphasize how important it is to provide staff and family caregivers with ongoing support and training, and to show them that this approach can work with small victories that build. So building rapport, validating their experiences, all these kinds of things will improve their willingness to take a leap of faith and to try implementing the non-farm strategies. So in summary, just hallucinations and delusions are very common in various types of dementia. Symptoms can be distressing for the patients and their caregivers, and we need individually tailored non-drug interventions that are based on the patient's cognitive abilities and their personal history and their current needs, because medications have a lot of risks and not a huge amount of efficacy. I went over a bunch of practical strategies, so assessing and identifying triggers through functional behavioral assessments, modifying the environment to minimize confusion and misperception, implementing reinforcement, right? Using positive reinforcement to encourage calm behaviors and alternative coping mechanisms, and equipping caregivers with skills to manage the distress, to validate feelings, and redirect their patient's attention effectively. And we talked about the keys for success, right? In order for the non-farm approach to work, we need to have consistent responding across caregivers and staff. We need collaboration amongst all the disciplines on the team, and continued monitoring, continued assessment, and tweaking the strategies to meet the evolving needs. And finally, in the future, what I'd like to see is for us to expand the research on ABA's long-term impact in dementia care so we can really build our evidence base for the non-farm strategies. I'd also, oh, I see a heart. Thank you. I'd also like to see enhanced caregiver and staff training programs to help people learn and integrate these behavioral approaches, right? We want to build capacity. We want more people to have this knowledge. And finally, I'd really like to see improved interdisciplinary collaboration to improve dementia care outcomes. So thank you very much, and I'm going to open for questions. Sorry, it's a bit over time. We just had some tech difficulties.
Thanks so much, Yael. So a wealth of knowledge, and I'm sure there's questions. I see Rhonda Feldman. Hello, Rhonda is asking a question saying,
Okay.
Tifa's recommended response did go along with the false belief.
It did.
How do you acknowledge distress without reinforcing the false belief?
So it's, I'm so glad you pointed that out, Rhonda, and it's true that she did go along with it. I think one of the things we have to think about is safety and risk, right? And it's maybe a cost benefit analysis, right? To help de-escalate someone, we might need to go along with it, right? Like even the example I gave with the CEO, we didn't say to him, you're not a CEO. We said, oh, we cleared your schedule. So I think we have to pick and choose, considering what harm, weigh the pros and cons. It's a toughie. It's definitely a toughie. I don't have a straightforward answer. If I had a specific example, I might be able to come up with something, but yeah, thanks for pointing that out, Rhonda. You're right. Oh, and I just want to say, I'm going to be giving Kara the slides, and you'll see here there's a lot of references that if anyone wants to do their own research, and then my contact info for questions. So those will go to Kara.
Great, thank you. So I see a hand up. Agnes, are you able to unmute Janelle Atkinson just to ask her question? Go ahead, Janelle.
Hi, Janelle, you're currently on mute. You can unmute yourself and you can ask your question.
Oh, sorry, I was talking to myself. Apologies. I just want to say first, thank you. This was great. I'm the behavior support specialist at an RCC, and my question is in terms of kind of everyone being on the same page. Myself and my team get that a lot too. We don't have time for someone who is trying to escape their peri-care, for example, for various reasons. And we too have mentioned, if you break down the task demands into smaller pieces, it works. We can coach and train the staff until there's a new bout of staff that come in. Is there anything that you would recommend to tell new staff who are coming in, who don't have the buy-in? Because we have 120 beds where we are, and it's challenging to continuously try to coach and train the staff on certain patients. But yeah, I'm just wondering if you had any recommendations for the staff piece of the education. We do all the assessments and find out what works, obviously, but you're right. If everyone isn't on the same page, it's not successful. It doesn't generalize. So yeah, sorry for my long-winded question.
No, it's a great question, and it's a really important one. I'm glad you raised it, because this is probably like universal to anyone who works in this field. And it is a huge challenge. So my recommendation would be to have staff education sessions, like half-day workshops, or even like 1 hour a week. And it could even be done on a drop-in basis. I don't know if you need to up staff in order for people to go and attend. You could create an e-learning module. So just like we have to do hand washing and all this other workplace harassment, like every once a year, have a model where we're teaching the rationale. I think it's when they don't understand the rationale, then they're not game. And one of the things I say is, look, I know you've always done it a certain way, and I respect that. I respect you. Oftentimes the staff are like older than I am, right? And it's like, well, what do you know? You're not here, or when I was on the unit, you're here, but we have a lot more experience than you. You're not a nurse, you're not a PSW. I get that. I'm not taking that away. But what I say is, what you've been doing has not really been working, has it? What I'm hearing from you is that what you've been doing has not really been working. Would you be open to trying something that might work? It might not, it's true, but it might. And if it does, won't your life be so much better? And sometimes staff need validation, right? Like sometimes I do psychoeducation sessions where it's really just support. It's building on strengths, saying, okay, this coming to work every day. Oh, sorry, I just saw. So coming to work every day is a challenge if you know that you're going to be dealing with people who are aggressive, right? And that's not easy. And maybe you don't want to come to work because of that. So having space for staff to just vent and to validate their feelings and how hard it is. Once we can deflate the balloon a little, then maybe they'll be more open to hearing some of the strategies. But ongoing education is key. And one of the ways to do it, another suggestion would be for quick and dirty, is the tip sheet. So I have a 1-pager that has pictures of different ADLs and then just tips. So it's right there in your face, Cole's notes of the patient. So even if they don't understand, even if it's a new staff, floating staff, relief team, whatever, they can look through it and quickly just see, okay, here's what's going to produce the best outcome for this patient. And just having that available. whether it's like slapped up onto the wall in the patient's room, or it's in the Cardex, or somewhere where people will look, just so that they know that these things are out there. I hope that answered. I mean, I could spend the next half hour answering that question, but those are just a couple things.
No, it did. Thank you so much. And we have monthly educations, just find that the turnover rate are they're just so high lately. And you're right. It's the
Yeah.
burnout. It's everything kind of accumulating.
Yeah. And this is the thing I say, there's an initial layout, right? There's an initial investment of a lot more time, but there's more bang for your buck at the end. And that's true with staff education too. It might take more time and upstaffing in order to get your staff to a point where they feel equipped to handle things. But then you're going to have so much better patient outcomes, and there's not going to be as much burnout.
Thank you so much.
Speaking of time, it looks like we are pretty much out of time. I saw that there were 2 more hands. Sorry about that, Lydia and Sam. Hopefully, Yael, are you okay with them just maybe emailing you directly?
Absolutely.
Super.
Yes,
So again,
absolutely.
ygoldberg@baycrest.org. So again, I apologize that we've run out of time, technical difficulties today, but thank you, Dr. Goldberg. You are phenomenal as always. And I always love having you chat. I'd like to thank everyone also for joining us today. Thank you for taking the time out of your day to build your capacity. Just a quick reminder that if you would like a certificate of attendance, please complete the brief evaluation, which will be emailed to you. The recording will be available on the Ontario CLRI and BSO websites. And once again, thank you so much, Dr. Goldberg. Have a nice day, everyone. Take care.
You're welcome. And maybe Agnes, when you put it together, just edit the technical problems, so it's just a seamless little, if you can.